Well, I've got Dr. Taylor Provost here with me. Hi, Dr. Provost.
Hello.
Dr. Provost was in our recent live patient treatment course in early October, and she had prepared prior to that course by taking the surgical placement fundamentals course and then the site-specific treatment planning course using CBCT imaging. And this October course was her first run with the live patient treatment course, and you're returning, gosh, just in 6 weeks or so for our December course, right?
That's right.
Great. Looking forward to having you. You did just such an incredible job at the last course. You did some really great cases. They had some unique features to them as well. And I was thinking maybe we could talk about that in a few minutes, but can you tell me about your professional background?
Yeah, absolutely. So I am a general dentist in Houston, Texas, or the Pearland, Texas area, if anyone is familiar. I've
Mhm.
been practicing for just over a year. I graduated in May of 2022. I had a very unique experience where I was pretty much thrown into a private practice where the owner, went on maternity leave. And so I was seeing all the patients, the only doctor in the office. So I had to learn things very quickly. So I was seeing all these patients that definitely, needed implants, and the desire and the market was there for implants, but I had only restored implants at that time. So I was doing a ton of bridge work and just found, the need to come take a course to finally just get my hands on it.
I see. And how soon into your new practice life were you feeling that way about implants?
Honestly, probably, I wanted to like really solidify my hand skills as much as possible, really
Mhm.
hone in on my skills. I didn't want to like jump the ball on anything.
Mhm.
But definitely probably around like March or April, given that I started in July, I was like kind of getting a little tired of like the bread and butter stuff and
Mhm.
kind of feeling like I was doing my patients a little bit of a disservice offering, bridge work. Um,
Mhm.
Granted that I would still offer them implants, referring it out to the oral surgeon that we do have come into the office. But I
Mhm.
felt like if I felt confident in myself to actually place implants, that I would be able to give them a little more value in the treatment.
Fantastic. And I think I remember you telling me when we first met that you have a desire to take this beyond kind of starter case level cases and
Yeah,
get into some full arch treatments, some hybrids, all on four kinds of applications. You still feeling that
definitely.
way?
Definitely. That's the goal. I want to take it step by step, do as many starter
Mhm.
cases as I can so that
Mhm.
it's just streamlining them, having lots of success with those cases,
Mhm.
so that I can go ahead and get started with some of those all on four cases, some of the
Mhm.
more complex prosthetic cases there.
Mhm. Well, from this point forward, with every starter case that you're doing, you can kind of do it with that in mind too. When you're incising and flapping, you're thinking about exposing the bone and seeing it across all the dimensions that you can. And then once you've done that several times, then a little longer span, full arch, and so on and so forth. Once the prosthetic part is kind of established and honed in too. But
Yes.
so here you are, 18 months later,
Yeah.
right around that timeline, and
Yeah. Give or take.
you've placed a few implants at the last live patient course. And it sounds like we were talking just before we started recording that you have treatment planned, a case to do right after you get back from the next course, right?
That's right. Yeah. Actually, today I was working on, workup for my patient and went on and sold a case. And I just thought it would be perfect to go ahead and get him scheduled. He wants to get it done as soon as possible. So kind of had to hold him off a little bit, but I have him scheduled literally as soon as I get back from the second or my second live patient course. So everything will be fresh. I'll be good to go to get ahead and get that started.
That's awesome. I'm proud of you and excited for you.
Yeah.
So, for anyone who might be watching this and they're wondering if this continuum would be good for them, could you tell me or tell us a little bit about your experience with the didactic portion of the entry point continuum as it led up to your first live patient experience? Were there Were there things that you learned that surprised you or that changed your thinking leading up to that? Or did it mostly just augment what you already know?
Well, definitely it took the unknown out of implants, I feel. You know, going into the course, I was, a little bit nervous, a little scared. It just seemed like implants, especially in school, at my school, we restored a lot of implants. The implant courses that we had, they were offered, but just never really got into how do we do this efficiently? How do we get this done? And I feel like the didactic portion of the course, especially the CBCT portion, just really got down to, the fundamentals and how do you repeat this process over and over and over again to ensure, to give the best prognosis of the treatment in the end. So basically the treatment planning steps that you give, to reading CBCTs, it makes it very predictable, which I appreciate a lot. And makes it, I don't want to say easy, but definitely a whole lot easier. I've seen a lot of doctors struggle with implants. They kind of go into it blindly, I feel like.
Yes.
But I didn't feel like there was anything that I was kind of slapped in the face with, if that makes any sense.
I think it does. And then I saw you come in to the treatment planning phase of the live patient treatment course and watched you very confidently manipulate Blue Sky Plan and bring that DICOM in and present what you were going to do to the group. And then I saw you go into the operatory and execute that. And then you buttoned it all up at the end and were able to present that. So I've seen what you're talking about.
Even when I got back to my office, we use a different CBCT software, but going through those steps, like it was still like ingrained in my brain. So I feel like that's the other cool piece in it. The CBCT course, the way that you guys just take us through the steps, you don't forget it. So even if you want to, it's like, oh, wait, shoot, I should back up a step, make sure that I have done this, this, and this before I jump ahead. So just learning those fundamentals, making sure that you have everything you need to come out with a predictable outcome.
That's great. And now here you are assessing a patient in your own practice after that experience. And as you mentioned to me a few minutes ago, he's site number 30. He's got great bone, and you feel like you're able to do that preliminary stuff so that you can be ready to go and execute the case confidently.
Yes, for sure.
That's awesome. How would you feel about looking at a couple of the cases that you did a few weeks ago, and maybe we could talk about some of their interesting features? That sound all right with you?
I'd love to.
All right.
Yeah.
We'll go into a screen share mode here. This is the Friday night patient that you treated.
Okay.
And I saw her at a post-op. Was that last week? I think it was 2 weeks ago now when I saw her at her post-op, and her healing looked great.
Wonderful.
So, yeah, beautiful job with the closure. She did not complain, and she was just grateful for the care you gave her. So I hope that makes you feel like $1,000,000.
No, it definitely does, because this was my first case. I was extremely nervous about it, but I just went in there and acted like I did know what I was doing, but just a little nervous. And so, but she was a great patient, and easy enough, we got it done.
You got it done.
Yeah.
What we're looking at here is some preliminary workup information that is taught in both the surgical placement fundamentals courses and then is put into practice in the site-specific treatment planning course. But you've drawn a crestal cross-section of the site and also a mesiodistal view, and then taken some specific notes that you can and did carry into the operatory. And you can see here that the ridge width was just really agreeable. Most aspects of this case were pretty agreeable, slightly lower bone density perhaps. And you had talked about lingualizing the entry point just a little bit because of the contour of the buccal plate.
Right.
Here is your paralleling pin radiograph. And do you remember making any corrections to that once you acquired it?
I did. I want to say on this case, I had to kind of kick the pin out distally at the at the apex.
Hmm.
It tends to kind of draw in mesially. So
Yes.
initially I went in, but I did have to kick it out a little bit distally, got my paralleling pin where I needed it to be, and then we went in with the implant there.
With a beautiful placement, as you can see.
Yeah, it was really nice.
Yes, and we like to have this little dialogue in the operatory that you know of, which is once you've placed it, we put a driver in there. And I think we have a picture of this a little later with the other case you did. But if this was the impression coping 4 months down the road or so, would you be thrilled with where it sits? And in this case, it was a big yes. You will end up here. Your eye kind of goes to the distance between the implant and the roots here. But more appropriately, really, are you entering through centered through the restorative space? And it's even better than it appears here. You're going to have a screw channel that goes right down the center of the occlusal there. So
Yeah,
just a beautiful placement. Well done on that.
thank you.
Yeah, you're welcome. Now this one, oh, here's your closure too.
Oh yeah, there we go.
What was your comfort level with closing uh, prior to the course? Was it already pretty high?
Um, I mean, it was there. I feel like I do it enough, but
Mhm.
definitely some of the techniques that you helped on. And it was funny because I didn't feel like that was something that I was really focused on in
Yeah.
the course,
Mhm.
but that was a skill that I definitely gained from the course because as I've been extracting teeth and closing up sites, I've just been like whipping through closing things. So definitely a skill that I gained just coming out of the course as well. But it was kind of not maybe unintended, but it seems unintended.
That's good. You made my day on that
Yeah.
too.
Yeah.
I think when you consider implant training, you really think about how to engage with the bone. And fair
Mhm.
enough, you have to learn that. But really, I think it's the entry and the closure that cause a lot of people to stumble because a lot of people kind of gain habits of creating an incomplete opening, incomplete
Mhm.
lapping and retraction, and then the closure can be a bit mystifying too. So it ends up being a big key for moving into full arch treatment too. So that's going to serve you really well.
That makes sense.
Yeah. So those stitches look great at her post-op.
Good.
Here's your other case. This
Oh
one
yeah.
upped the ante a little bit compared to that single bounded span that you did on Friday night. Do you want to tell us about
Right.
this one?
Yeah, definitely. So this case was a terminal span. The patient had recently had number 13 extracted, had number 14 extracted, but 14 had a little bit more healing time. So the bone on number 13 was definitely a lower density bone because some graft had been placed, but of course had not necessarily been, had not matured, basically.
Hmm.
So we knew that it was going to be a little bit more of an immediate, closer to like an immediate placement than it would be just a fully healed edentulous site.
Hmm.
And in this case, we had to, just maneuver our entry point just a little bit, make sure we lingualized the entry point to engage in the bone. Something that we considered a lot was gaining stability and keeping it.
Yes.
So that was something I was very diligent about, um, especially on that number 13 site. And then, of course, we end up getting it. I got it a little bit faster than I expected to. I thought that was
Yeah.
going to be the nuisance there, but really it was, paralleling that number 14 as well, making sure that we were
Yes.
good to go there. So that was a little bit of a tricky one too.
Yes. Yeah. The case had features that were challenging that we didn't really anticipate in the treatment planning session. And you really sailed through that number 13 site. And in fact, here's some radiographic evidence. First of the preoperative site. And of course,
Yeah,
you can see the walls
the
of that socket.
defect.
Yeah. It turns out, though, that you're able to get some pretty good engagement in this region. You didn't
Hmm.
really have to treat this as an immediate as much as we anticipated, which was
Yeah.
just great. Your paralleling pin had just a really good location, angulation, depth. And then here's your final placement on 13.
Yep.
Yeah, just beautifully done. So then
Yeah.
the challenge, as you mentioned, was to gain parallelism with that first one. And we employed a couple of different techniques here. And you can see a
We used one of
driver.
the, yeah.
Yeah, and that ended up being a challenge just because of kind of maneuvering around that driver. So it made a good gauge, but then it was tough to kind of work around it. But
That's right.
in the end, you ended up with a really beautiful placement of these implants. And then, and it's interesting too, you can kind of see the evidence of the socket that was there as well.
Hmm.
A gorgeous placement in the end. And in your case, you had an unusual closure. Can you
Yeah.
speak to that a little bit?
Definitely it was an unusual closure.
Yeah.
I started to socket. I mean, I started to go ahead and close the sites. We knew that we were going to go ahead and place a cover screw in there instead of a healing abutment, just so we
Yes.
could ensure stability of the implant over her healing time. But as we decided to go ahead and close it, we could not get primary closure.
Mhm.
To me, it felt like her tissue was just so dense that I couldn't
Yeah.
close it. But Dr. Hillam's experience definitely came into play, which was nice. Um, it may be that we assumed that the implant could have expanded the bone a little bit.
Yes.
And so we couldn't necessarily get the primary closure we needed. So we
Mhm.
had to actually do some soft tissue manipulation in order
Yeah.
to get that closure.
Yes, and we did it in a couple of different ways. We very quickly moved from the realm of a starter case into something else. And the first thing we did was a periosteal release.
Hmm.
You can see this papilla between 11 and 12. And we had this papilla opened up and things reflected a bit more than what is depicted here in this photo. We really had a nice, well, pretty mobile flap, but in order to mobilize it a little bit more, we did a very careful incision on the inside of that flap of the periosteum, which was the only thing preventing that flap from having enough elasticity to come back to a state of primary closure. So,
Right.
so we did that, right? Yeah. Then we also did something that's just such a nice technique to employ with implant placement when possible, especially when you don't have a lot of keratinized tissue out to the buccal, or you have some sort of a defect where you just wish that you could get a little bit more volume in that region. We did a subepithelial connective tissue graft and harvested from the palate. And you can see right here between this driver and this implant, there is plenty of subepithelial connective tissue that can be harvested in that region. There are two options, really. One is to mobilize it entirely and treat it as though it's a standalone piece of tissue and embed it into the buccal flap and close. Or the other option is to actually leave it attached to its blood supply in the manner of a pedicle. And so we did the latter. We did a kind of a sliding pedicle, and it got this needle holder in the way here, but it was a rectangle about this these dimensions, and the blood supply remained intact, and it was rotated and tucked into the buccal, and
Yeah.
added some volume, and will ultimately add some a little bit more attached keratinized tissue out to the buccal of that implant. So that was a really cool case.
Definitely. Definitely lots of learning points from that case,
Yes.
which was cool to have. So
Yes, and it was one of those moments where, I like to say, in a highly mentored environment where you do a live surgery, and that's was kind of one of those moments where the patient ended up getting some things that just went outside the bounds of a normal starter case. And I really wish I should have FaceTimed you during her post-op, because she was one of those patients who used the phrase, "I didn't have any pain." How do you like that?
wonderful. I love that. She was an amazing patient. But
Yeah.
that's wonderful.
Yeah. Isn't that amazing to hear? I would have guessed that she would have had some pain because a lot of times a periosteal release and then, of course, a palatal harvest will
Right.
cause more post-op pain. But she did not complain of pain. It could speak, of course, to her character and to her
Hmm.
pain threshold. But still, what I saw after 2 weeks was pink. I didn't see redness particularly. There's maybe a little bit still of some inflammatory activity going on there, but for the
Hmm.
most part, it was just beautiful. You would have been so proud uh,
Good.
if you would have had the pleasure of taking out her post-op sutures.
Oh man, yeah.
Well, so good. Beautiful job, Dr. Provost.
Thank you so much, Dr. Hillam. It's been fun. Definitely can't wait to come back to do more cases. Just got to get my hands in there.
Absolutely. The learning issues that will come from your next round of cases will just push you farther down the road, and then you get to a point where you start to see repetition and you start to see variations on the same theme, and pretty soon you get those reps in, and then you're ready for solo flight, yeah, as I like to
Yeah.
say. Maybe something I'd like to point out too to anybody who's watching is that you're contemplating bringing your own patient to one of these life patient courses as well. Can you tell, we talked about it a few minutes ago, but can you tell me a little bit more about that?
Yeah, of course. So I have a younger patient. She's only maybe about 35 years old, and she does have some health conditions that I guess caused her to lose her teeth earlier in life. And she's wearing a partial. She never takes the partial out because she's embarrassed.
Yeah.
I try to get her to take it out as much as possible, but
Mhm.
she definitely, keeps asking about the possibility of implants. And
Mhm.
so finally, got her to take a CBCT in our office, and I was just assessing her. I knew the width of the bone was good, but I was concerned about, maybe her sinus had to pneumatize, things
Yeah.
like that. But
Yeah.
she has absolutely beautiful bone. And
Mm.
so that's when I, asked you whether or not that would be a good candidate as far as
Yeah.
placing several implants in order to restore
Mhm.
for her so that she can just have a better quality of life.
Yeah, that's great. And we'll look at that scan together and do some planning. And hopefully, you'll be able to bring her to an upcoming course. And
Yeah,
it's going to be, I think, a really tremendous way to benefit her and, of course, you as well.
of course. Yeah, no, she's got some, probably could at least get 5 implants on her, which
Hmm.
which would be awesome.
Hmm. Well, great. Yeah, that's something I wanted people to hear. That's something that anyone can do. And we're pretty close to the airport. And so far, patients have been thrilled to come. Dr. Holt brought a patient last time and did a full
Mhm.
lower arch for her. And I think she was really happy with the result. And so that's something that can be done. Well, any final words of encouragement to people contemplating the course, or any other thoughts or observations from your experience so far?
I mean, it's definitely just you have to do it. Whether implants are it is something tricky. There is a learning curve to it.
Mhm.
Finding a course. One reason why I definitely like this course is because very hands-on, smaller classes, and then also just the patience that from the instructors, the knowledge
Mhm.
and the patience from the instructors definitely was something that I appreciated. I never felt overwhelmed. I never felt
Mhm.
like I didn't have the space to ask questions and things like that because I can
Mhm.
get into a couple of spaces where I don't feel comfortable
Mhm.
asking those. But there was never a moment in time where I didn't have
Mhm.
that. So I felt like I got the best education in implants that I possibly could have with this course.
Good. Well, what I love about what you're saying and what you have said in our time together so far is that you have the demeanor and you're using the language of an implantologist. Uh, it's evident that that's already happening for you,
Yeah.
and you're going to come into this game very trained, and you're not being informed by a philosophy that says, hey, this is easy,
Hmm.
just come do it. My message isn't that this is easy or simple necessarily,
Definitely.
But my message is that you can do it with the right training, and you
Mhm.
can do it in a systematic, safe, controlled way, starting with starter level cases, and then inevitably you'll expand that circle of experience and understanding to include other things. And of course, uh, you can use uh, you can use my services however you like as time goes on. For that, as you want to engage with the sinus and you want to maybe do some more soft tissue grafting or some ridge augmentation, things like that. But you have a framework now that's growing, but that is established for starter level cases. That also, what I like about it is, as you do go to other courses, which you of course will and should, you'll have a framework where you can plug that information in that you get in those
Oh,
courses.
of course.
You can put that into that that's what's missing a lot of times, that framework. So I can
Yeah.
tell that it's already beginning to be inculcated into your speech and your thought patterns as we approach and discuss these cases. And that's really gratifying and exciting for me. So congrats, and you're well on your way. And thanks for joining me tonight.
No problem. Thanks for having me, and I look forward to the next one.
Sounds great, Taylor. Thanks a lot.
Of course. Have a good one.
You too. Bye-bye now.